The clinical picture may seem obvious, but a second look can sometimes be decisive. Above all, rare diseases are difficult to diagnose at first sight. In Europe, 40 to 50% of the people affected are misdiagnosed at least once. Indeed, the correct diagnosis is never made in many cases. This group of orphan diseases also includes the fatal type of childhood dementia known as neuronal ceroid lipofuscinosis, NCL. The consequences are tragic for the child and family and serious for the doctor. Juvenile NCL, which is also referred to as Batten disease, is an autosomal recessive metabolic disease. It's crucial to establish an early diagnosis to ensure that affected parents are aware of it with respect to future family planning and, of course, the treatment of NCL children. It's easy to diagnose an NCL disease if you've already seen one. The problem is that the disease is so rare. The affected CLN3 gene is located on chromosome 16. It encodes for a so-called lysosomal membrane protein. The lysosome, which acts as the recycling center for cells, no longer functions as a result of the genetic defect. This leads to the accumulation of characteristic deposits, ceroid lipofuscin, which puts NCL into the category of what are called lysosomal storage diseases. NCL primarily affects the nerve cells, first the retina and then the entire brain. Loss of vision is the first symptom of juvenile NCL.
When he was looking at television, he was sitting 10 centimeters from the screen. So we thought, this is not normal.
He also played soccer. And the thing is, he didn't follow the ball. He only started running when the other kids started running, so he didn't see the ball. We found out afterwards.
And we thought he needed glasses.
At the same time, some cases show evidence of a drop in school performance. From primary school age, the affected children gradually lose their ability to see, move, speak, and act. In the final stage of the disease, the body is no longer able to perform its vital functions. Young patients die. The typical scenario involving a patient suffering from the juvenile form of NCL is that he suffers loss of vision during school time. The child is usually taken to the eye doctor, where an eye specialist takes a look at the problem. The examination primarily checks to see whether the child requires spectacles to correct the vision problem. And this is in fact the crucial moment. If the spectacles don't work to restore the child's vision, or if the parents report other symptoms, such as difficulty seeing in the dark or increased glare sensitivity, it's then imperative to listen attentively and take further examination steps. Further diagnostic tests should be performed as a result. Specifically, the pupils should be dilated to allow a closer look at the retina and optic nerves. The juvenile form of NCL generally causes a noticeable change to the retina. Changes can also be seen to the macula. In particular, little can be distinguished on the periphery, and when an eye specialist has identified such changes, it's time to send the child to a specialist diagnostic unit, usually at a university hospital. Further diagnostic tests should be then carried out at the eye hospital, such as the use of optic coherence tomography to establish any damage to the photoreceptors, as well as subsequent testing using an electroretinogram ERG. Already in the initial stage of juvenile NCL disease, the ERG potentials are no longer detectable. With juvenile NCL, the fundus aspect often exhibits a so-called bullseye maculopathy. This type of change to the macula is caused by various diseases, including cone dystrophy and Stargardt disease. If the ERG test has been recorded, and it has been established that no more potentials are detectable, Stargardt disease can virtually be ruled out as a differential diagnosis, because it usually or almost always continues to show very good potentials in ERG. In general, cone rod dystrophy is not as pronounced in children aged 5 to 8 years, to the extent that rod potentials are also no longer traceable. We are therefore dealing with a generalized form of tapetoretinal degeneration, often referred to as retinitis pigmentosa. At this point, it's very important to get an idea of how fast this disease is progressing. The patient should be scheduled for another visual acuity and field test in as little as 6 months' time, and not after 2 years, as is usually the case. If such a fast progression of retinal disease is detectable at this age, it's imperative to consider differential diagnoses in addition to the typical case of retinitis pigmentosa, and this is exactly the point at which juvenile NCL should be considered. If these 5 criteria are met, the suspicion of an NCL disease should be clarified by a neuropediatrician or human geneticist.
Wenn Sie den Verdacht einer NCL-Erkrankung haben,
If you suspect an NCL disease, you can test this by carrying out simple laboratory tests, such as a blood smear. If significant lymphocyte vacuoles can be detected in the blood smear under an optical microscope, juvenile NCL disease is therefore probable. And this can be further ascertained by carrying out molecular genetic tests. With juvenile NCL disease, this is particularly easy to identify, as around 90% of all patients show the same gene mutation. Generally speaking, all cases of NCL disease result in a cerebral atrophy. In other words, the grey brain matter is significantly narrowed. In many types of NCL disease, this also serves as an important diagnostic tool that can be proven by the MRT. Nonetheless, this appears at such a late stage in the progression of juvenile NCL disease that it plays a subordinate role for the diagnoses.
At first, the ophthalmologist told us that our son had a pigmented retina, and that was all she said. We went home and we looked on the internet, and then we thought it could have been retinitis pigmentosa. And then a friend of ours, he said to us, it could also be TRD, which is tapeto-retinal dystrophy.
After that, we went to a doctor specialized in metabolic disorders, and it took him 6 months to tell us that the real disease was Batten NCL, and that was the end of the long way of getting a diagnosis. We knew what was the disease, but it was the baddest answer we could get.
Unfortunately, no causal treatment for the NCL disease currently exists. This means that we can only treat patients symptomatically, and the main symptoms requiring treatment are cerebral seizures. In an emergency situation, we recommend using benzodiazepine, which can be administered via the oral mucosa or rectal mucosa. Further, in the course of treatment, it's also important to deal with personality changes, such as the appearance of psychiatric symptoms, which need to be treated with antidepressants or antipsychotics. In the latter stage of the disease, it's vital to treat spasticity with antispasmodics, in which case orthopedic equipment is required. Ultimately, most patients have to be fed with PEC probes. It's vitally important to include the parents and prepare them for the death of their child by providing appropriate psychological treatment. NCL is the most common form of childhood dementia. The loss of ability to speak is the most serious turning point for families. Another crucial point relates to the way in which the parents are informed of the diagnosis. It can often be a truly horrible experience, yet parents may be told over the phone with the news simply thrown at them, and it burns into their minds. The parents never forget how they were told. The goal of the NCL Foundation is to bring researchers and doctors together and inform them through further training measures. The Foundation serves as a centre of knowledge for juvenile NCL. Above all, it focuses on supporting early-stage researchers across the globe in their research to develop a drug against NCL.
Some of the most promising results in JNCL research as regards therapy really center around studies that show that certain cells in the brain can be corrected by oral administration of drugs or intravenous administration of drugs. And there's a variety of approaches that are being taken, from anti-inflammatories to other molecules that affect the way these cells misbehave. I envision that we will be testing drugs in JNCL kids within 2 to 5 years. There are some very promising medications on the horizon. Healing is a long-term possibility, most certainly, for JNCL.
Early diagnosis is the basic prerequisite for successful treatment. If you have any more questions, we will be happy to provide you with further information.